Clinical Excellence. My name is Dustin Jones. I am one of two faculty members with the Older Adult Division with my partner in crime, Christina Previtt. I've got an audience today. This line is mean mugging me over here, but I'm in my daughter's room just to get away from some of the chaos downstairs. So we got a different location, but hopefully we'll bring some of the same good content to help you throughout your day. First thing before we jump into today's topic, modern management of the older adult. We're getting things rolling, people. So we just finished our most recent online cohort. The next online cohort is January 13th. So sign up for that if you want kind of the 8-week online interactive experience. We get together every couple weeks online to talk through cases and different questions, and you can kind of go through content at your own pace. Also, our first live course, St. Louis, December 8th and 9th. That's coming up quick. Christine, I would love for you to join us. We'll both be out there at HouseFit in St. Louis. So today, what to do when perception doesn't match reality. So this past week in our discussion for MMOA Online, I shared a patient case that has really been interesting and just something that I'm thinking more and more about, as it's pretty common in my arena. But I'll just tell you about the person that I'm working with. I'm going to see in about an hour and a half. So this person has COPD, anxiety, depression, basically decades of dysfunction or something that is wrong with her. Doctor's visits every week, about 20 medications, kind of a typical patient that I work with, and maybe some of you all as well. Good morning, Brittany. PT doesn't ever help her. They always do too much. They push her too hard. She hasn't had great experiences, but all she wants to do is walk further. That's all she cares about. She's on 2 liters per minute continuous of oxygen. So she just wants to be able to go further before she has to sit down. And I sometimes slip up and make the mistake of asking, how are you feeling? With some people that can be a great straightforward response. With other people, that's, a 15-minute conversation. But she always responds with, I'm feeling terrible. I don't feel good. I'm not getting any better. Just very pessimistic. And not always, she's not always the most chipper person. So she's just kind of hard on herself and saying, I'm always feeling like crap. I'm always feeling like crap. And I can't blame her, because if you look at her medication list, she's not moving a lot. She lost her husband a few years ago. She's in an assisted living facility now with some social interaction. But I can't blame her. But we're working together. And the really cool thing is that over the past few weeks that we've been working, she's making tremendous gains in therapy. Now, she's improving literally each visit with the interval training that we're doing. She cares about being able to walk to the dining hall, so we're going to do lots of walking, and we made it kind of interval-based to make it more manageable for her with her COPD. So we're just walking basically as far as she can handle, and then she sits, and then we rest, and we do it over again. Very, very simple. I know this sounds very elementary, but it's working. I'm measuring each time, and she started off in the 180s for each bout of ambulation, and now she's well over 250 feet each time that she's going to walk before she needs to stop. But I still ask her, how are you doing? I'm doing terrible. I'm doing terrible. And over basically this week, she's really kind of changed her perception of how she's doing, because over and over again, I'm showing her these numbers don't lie on my little measuring wheel. You used to be able to do one bout for 180 some feet. Now we're doing over 250 consistently. And she's really starting to buy into our process. And that really got me thinking, what do you do when perception doesn't meet reality? Because this is a common scenario that I definitely experienced, but it kind of goes both ways in terms of people not feeling like they're getting better when they actually are, or they think they're doing great when in reality they're not. And these are both scenarios that we often find in physical therapy. So let's go with the first route. What do you do when your patient doesn't perceive progress when there is progress? So I think, like many things, the better we are on the front end, that's really going to influence our success or failure. So we have to do the front end work and nail down that initial visit, that evaluation, that subjective history. We got to be patient-centered. So the questions of what does a good day look like? What will you consider success to look like as we're working together? We need to really capture what they want to achieve and their desires, and make sure we have a clear connection between their desires and our intervention, that they know that when they come and work with me, I'm going to be able to get them to where they need to be. So it has to be patient-centered. But also, when you're leveraging some of your objective measures or outcome measures, whatever setting that you're in, you want to make it matter to them. And this is very, very common in the world of home health, where we sometimes are required to perform all these different, functional outcome measures that half of them the patient could care less about. I care more about them than they do. For example, my patient, COPD, I did a SPPB, which kind of, measures overall function and balance as well. She could care less, how quick she can go up and down from a chair 5 times, or, how, if she can hold, a tandem stance for 10 seconds. But she cares about that 2-minute walk test for sure, because that's testing her endurance and it actually equates to her goals. So that is an objective measure that I'm going to leverage whenever we do a reassessment, for example. I can show her, man, look at this. But, on day 1, you did this. 30 days out, you're able to improve that dramatically. That's going to speak loudly to her. Let's say you have someone with low back pain. They may not care about that Oswestry score. I'm just saying, but they may care about how much they can lift off the ground, or if they can lift their groceries out of their trunk, or be able to walk, 50 feet with 15 pounds, for example, to mimic carrying groceries into their house. So the objective measures or the outcome measures that we choose, I feel like, have to really matter to that patient. So we have to be very selective. Second, we need to help tell the patient's story. Sometimes we need to remind the patient of their story, of where they have come from. So way back when, I think it was over maybe a year ago now, I did a PT on Ice called Be a Guide, Not a Hero. And there's 3 characteristics of being a guide in therapy. 1, a guide doesn't do the work for the hero. So the hero in our scenario is often the patient. We want to show the patient what they need to do, kind of the path that's ahead of them, and let the hero do the work. Second, we want to show the hero what lies ahead. So what can they expect on this path of recovery or to improve their performance? But third, and most important to this talk, is we need to show the hero where they have come from, where they've been. We need to help them reflect on their past, how they were functioning when before they saw us and when they first started seeing us, and where they are now. Now, we can do that with words, and we often do, and I definitely, we need to be talking about these things, but I want us to think outside of the box and really leverage other mediums to tell their story, to show the patient how far they have come. So a video is very, very valuable. If you can show someone the difference in their gait pattern, for example, or how they're getting up out of a couch or chair, whatever type of movement, you can show a difference from a video when you had them on day 1 versus 30 days out, and there's a big change. That can speak very, very loudly, more than your words often do. Also, you can use something like a graph. I've done this with timed up and go scores, for example. When I say, Betty, when we first started, you got 21 seconds on your timed up and go, and today you got 14. And I'm geeking out. I'm all excited, and she's like, "What the hell are you talking about? I don't understand why that would be important." We have to kind of show them the significance in that change, and a graph can do a great job of that. When versus me saying 21 seconds to 14, they see a 21-second point on that graph and then a 14-second point on that graph, and a dramatic decrease in the time of their timed up and go. That picture, that image can really demonstrate their progress and show how far they've come. So just think about how you can leverage things beyond your words to show people how far they have come, to really see, they have progressed, under the course of your care, and not to necessarily base everything on how they're feeling or their perception. So the other scenario, so the flip side, when your patient perceives progress or high performance when that's not the case. We've all had this as well. I'm doing great. I don't think I need PT anymore after we've been working for 6 weeks. I'm good, as they literally, trip and stumble out your clinic. Or I'm doing fine. I don't need any PT. We'll do this evaluation today, but you don't need to come back. Common in home health, probably common for many of you, when the doctor just, writes the script and the patient just follows what the doctor says. So the first question that I feel like we have to ask is, does this misperception put the patient in danger? Is this a safety hazard? If this is not a safety hazard, if their misperception of their functional ability is not imposing a dramatic risk, then I don't rain on their parade. Oftentimes perception or expectations can influence outcomes, functional outcomes, as well as perception of pain as well. So I'm not necessarily going to rain on their parade. But if there's danger, if their misperception puts them at a risk of harm, I'm going to do my best to intervene. And what we most commonly see in the older adult world in Jerry PT is in the world of falls risk or balance. I'm doing okay. I don't need that walker. My balance is great. I don't need PT. Just go along with your day. Very, very common. So if that's the case, we need to do everything we can to try and help them. So the first thing that we need to do, once again, is to be patient-centered. We have to make our plans of care matter to them. If they care about walking to their mailbox, without losing their balance, for example, your interventions need to clearly demonstrate how that's going to help. Sometimes when we want to work on our tandem stance or semi-tandem, or put them on blue foam, for example, they don't necessarily care about that. Even though we know it may correlate, it may not be very clear to them. So we may want to do things that are very, very tied to what they care about, what matters to them. So we have to be patient-centered. We want to think about building the bikes. This is where you can take some of the asterisk signs that you may have gathered on that day one, that evaluation, and be able to demonstrate change. So let's say they're wanting to walk to the mailbox, and you do that. You walk to the mailbox. You may put a gait belt around them to make it safe, and they really struggle. They trip when they come off the sidewalk, for example, or they get out of breath, whatnot. You can time them, video it, whatever. Kind of get that baseline. Then you can retest that with maybe the implementation of a cane that you think would be very helpful for them, and you can demonstrate the change that you're able to provide for them with one simple change, with one simple fix, and that can speak loudly to them to buying in to your program. Now, if you're not able to really win them over, convince them by being patient-centered, or really starting to build the bike, like we talk about pretty often here at ICE, sometimes we have to demonstrate the need for our intervention or our help. And this is not always fun, but sometimes we need to set our patients up for failure. So it's maybe something that we know that they cannot do, like a single leg stance trying to hold for 30 seconds, for example, or a tandem stance or semi-tandem, something that they're probably going to fail, to be able to show that, hey, your balance is not as great as what you think it is, and if you're not able to do this, you're likely at risk for falls, or you're going to have a difficult time walking. So sometimes you need to set them up for failure. And then lastly, we may want to get the family involved. If there's danger on board, if there's a safety risk, sometimes family can help. Family can hurt the situation as well, but hearing from family members, concerned family members, or even friends of people that care about this patient, that want them to undergo therapy or some type of intervention, can be helpful. So let me recap what to do when your patient does not perceive progress when there is progress. One, do the front end work. Be patient-centered. Make sure you tie the intervention to their actual desire. You want to leverage outcome measures that matter to them, so when you're able to demonstrate change, they actually care about it. Tell your patient story. So be a guide, not a hero. Show them where they've come from, but be creative. Don't just rely on your words, but you can use video, you can use graphs, whatever you think would be helpful, but really demonstrate their story in different mediums. Now, what to do when your patient does perceive progress or high performance when that's not necessarily the case. Once again, we have to be patient-centered to tie their desires to our intervention, so they can see how we can help them do X, Y, and Z better, faster, stronger. We want to build the bike, leverage those asterisk signs so we can demonstrate change, so that they will see that I am able to help them. And then sometimes we have to set them up for failure to demonstrate the need for an intervention. So if this was helpful, share this, please. We love to really engage kind of our professional circles, get a good conversation going. So share this video if it's helpful, or share the podcast. Leave a comment if you have anything else to add to the conversation, or a critique. We love both. But don't forget, December 8th and 9th, MMOA Live, Modern Management of the Older Adult Live in St. Louis with Christina Previtt and myself. We'll be at HouseFit. 2 days, jam-packed weekend. We're really excited about that. And then also January 13th is the next online cohort of Modern Management of the Older Adults. So January 13th, 2019. So thank y'all for your time. I appreciate ptonice.com for the links, and I'll put some reference links in this post as well. Y'all have a good one.